going to discuss the sleeve gastrectomy, one of the important bariatric procedure. Obesity is now epidemic, and 36% of the population of the United States of America is morbid obese, and more than 50% of the population of the USA is obese. It has been estimated that by the end of 2020, 50% of the population of the world is going to be morbid obese. And bariatric surgery is the most commonly performed gastrointestinal surgery in the United States of America. Obesity is second most leading cause of the preventable death. What is the first most leading cause of the preventable death? Smoking. You are correct. Trauma means road traffic accident is the first most common cause of the unnatural death. But it is not preventable. We cannot prevent the injury. Nobody wants to get the accident. Accident is accident, which cannot be prevented. Everybody wants to prevent, but sometimes it happens. But obesity can be prevented. Smoking can be prevented, isn't it? So this is preventable. And it is alone never comes. It comes with a lot of comorbidity. If you will see obesity, then NIDDM, hypertension, cancer, gallbladder disease, renal failure, stroke, heart failure, atherosclerosis, all comes with the obesity, and responsible for approximately 5 million deaths per year, 14% of all cancer death in man, and 20% of all the cancer death in women is related to the morbid obesity. Historically, it is poorly defined that if the greater than 100 pound, then it is morbid obese. Very difficult to compare scientific basis, but normally the BMI is considered as the correct criteria, and BMI, if it is less than 20 or actually it is 18.5, then it is underweight. From 18.5 to 24.9, it is normal weight. For 24.9 to 35, it is obesity, and more than 35 is morbid obesity, and more than 55 is super morbid obese patients, like sumos or many of the races. Weight loss, you have many options. Diet is there, exercise is there, counseling is there, weight loss programs like Jenny Craig, Weight Watcher, these all programs are there. Old mentality was that it is a gland problem, lack of willpower, eating disorder, and addiction. Some people were they saying. Diet is extremely prominent in media. People are saying that diet is very good, we should do, but from the medical standpoint of view, diet is invariably ineffective. Diet works in the overweight patient, diet works in obese patient also, but diet never works in the morbid obese patient. You cannot expect that you do the dieting and your weight will reduce, and actually almost all the diet is invariably 98% of them they fail. Consequences are that more anxiety, more depression, and more depression means more eating, and after that weight further increases. We should understand why diet fail, because of hunger, 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 and always hunger. Why hunger? Because at the time of dieting, ghrelin hormone is produced more. As we know that ghrelin hormone was first discovered in year 2000, which is produced by the stomach in the lack of the food. If a stomach does not have a food, then it starts producing ghrelin, and ghrelin is a hunger hormone which creates hunger. So, if there was a study in which the comparison was done in the serum ghrelin level of a diet person or a healthy person, in normal person ghrelin has a diurnal variation, different time, like maximum ghrelin if you will measure in the serum, then maximum ghrelin is at the 8 o'clock, then again 1 o'clock, and again 8 o'clock. That is why this is our breakfast, this is our lunch, and this is our dinner. If it varies, suppose I will tell you to take a breakfast at 12 o'clock at time, then you cannot take, or in the early 3 o'clock in morning you will not like to have, and if I take you to have a dinner at 5 o'clock at evening, you cannot take. So, exactly the ghrelin level is variable in the races and country to country and the different ethnic region. That is why our time is, and it is synchronized with the level of the hunger. If you will see the level of the ghrelin in normal person and diet person, then also it is variable. The minimum of the diet person is maximum of the normal person. This is a graph, this graph is showing the normal level of the ghrelin, and you can see when the ghrelin is at the peak in the diet person, it is on the bottom. So, that is why always the people who do a diet, they feel always hungry, and sometime their threshold of tolerance will go and their hypothalamus is reprogrammed, and they say, okay, let us eat this time, and from tomorrow I will definitely do the diet, and this tomorrow never comes, and then that way they have the fail of the dieting. Sometime if they will do the diet for few days, then again they will have a big meal and they will just compensate all the lost weight which they have done. So, if you will do any surgery like gastric bypass or sleeve gastrectomy or other, then it is called as positive reinforcement. If you see the ghrelin level of the diet person is in the upper graph, this is the ghrelin level of normal person, and this is the ghrelin level after the bypass. So, it is called as positive reinforcement. So, it is much low, and that gives you the very good outcome in the patient after surgery. There is also one more this concept, that is called as concept of thrifty gene. Thrifty gene was present in some of the races in our ancestor. When our ancestors were in the forest, at that time there was no Pizza Hut or McDonald's. Right now the food is a phone call away from you. You call a phone and food is available within half an hour to you. But at that time they have to work hard to earn their food, because they were in the forest and they were spending a lot of time with the animals and with the extreme climate. So, in the healthy season they were eating a lot and they were gaining the weight. But once the healthy season is over, they have bad climate, and after that in that bad climate they were going into the shelter, they were going into the groove, and they were staying there for many months, 1 month, 1.5 months, and that was their period of hibernation. At that time they were not eating at all and they did not feel like eating also. Why? Because in their body the fat was secreting the leptin hormone. Leptin is a hormone which is produced by adipose tissue, and adipose tissue will produce the leptin, and leptin go to the brain and it will program the hypothalamus, and once the leptin is there, there will be no any hunger, and they were sleeping for many weeks. They are not willing to come out of their shelter, and at the same time their glucose level was also maintained. So, they do not feel weak also, because leptin works on the beta cell of the pancreas also, and it decreases the secretion of the insulin, and insulin secretes, that is why glucose level of the serum is high, it is maintained. No, they do not develop hypoglycemia, their glucose level is good, normal, and after that once the entire fat adipose tissue is depleted, then they were getting again arising from the, and they were getting hunger, because no more leptin is there. So, they were becoming hungry. By the time bad season is over, healthy season comes and they keep on eating a lot, waiting gain. But today leptin is working different way. Today what is the problem? That there is no extreme weather. Whatever the weight they are gaining it, that they do not have a time to lose, because food is available every time, and then they develop diabetes. As we know, the diabetes is one of the problem which comes together with the obesity, and that is one of the reason is leptin, because whenever patient is obese, beta cell will decrease the secretion of the insulin because of the thrifty gene. Although this is not 100% proved, but hypothesis is there that it has a genetic background and genetic control. So, these are the things which coming in the, and essentially there are many surgery which can great degree of success you can get, higher compliance you get. There are a lot of comorbidity also which comes with the obesity. Most common comorbidities are metabolic, degenerative, neoplastic, and the psychological. Metabolic comorbidities are like type 2 diabetes, hypertriglyceridemia, hypercholesterolemia, fatty infiltration of the liver and hypertension. These are the most common metabolic comorbidity which comes with the obesity. Obesity does not comes alone, it brings a lot of other diseases also together, and most common are these metabolic. After that, once the obesity remain for long time, then there are a lot of degenerative comorbidities like degenerative joint disease. As you know that people who are obese, they have the pain in the knee, they have pain in the hip, they have pain in the back, and sleep apnea, congestive heart failure, GERD and stress urinary incontinence. This is also one of the important degenerative and long term consequences of the diabetes like renal failure, stroke or amputation. Long term consequences of diabetes are also responsible. So, these degenerative problems we have to keep in mind. Now, there are a lot of psychological comorbidities also which comes together, that is anxiety disorder, depression and social avoidance. These are the psychological comorbidity. Anxiety disorder, as we know that whenever there is a obesity, it is a people who are depressed because they cannot do their work very nicely, and depression it comes because of social avoidance and together with the inability to get a proper progress in the job, proper progress in the community, and social avoidance means girlfriend does not want to remain with you if you are very much obese, wife will try to divorce. So, this social avoidance will create more depression and more eating. So, this is also a comorbidity, because psychologically if you are also not good, that means you are ill, and that is also is one of the factor. Neoplastic comorbidity also comes with the bariatric patient like breast, uterine, gastric, esophageal, hepatic and the pancreatic cancer is increased after the BMI 35. According to the Journal of American Medical Association 2003, it has been published that the white male after 40 years of the age which has a BMI more than 40 experienced 22% reduction in the remaining lifespan. 22% reduction in the remaining means they die early. You know, once upon a time sumo were made, nowadays it is banned. In the TV you are not seeing sumos, no more, because USA government has given a strict legal order, and if sumo will be produced now, then there will be a penalty and sentence in the jail. What was the sumo? That in China and in the Japan, in some of the places, there was factory of the sumo. So, child which is 2-year-old, they were giving no milk, just the oil to drink, oil, concentrated oil, complete fat, and instead of milk they were drinking fat, direct raw fat with full of triglyceride and the cholesterol, and then slowly building up weight. By the age of 18 they will be sumo, means their belly will be touching the floor and they are so fat sumo, their neck and everything is like that. And it was $1 million industry, because sumos big demand in the market for sumos. People were coming to see the sumos, and when the two sumo fight, the people they spend millions of dollars in the competition and this type of industry. And what was the life of the sumo? 30 years to 35 years. Within 30 years they will get heart attack, atherosclerosis, and they die. Maximum age was 35 years. So, that is why government has banned, because it is a cruelty, and that means you are taking a life of a person for earning the money, and that way it is stopped. So, exactly obesity is a cruelty on the life, because obese patient they cannot survive for long time, and it is a important thing to keep in mind. So, this was published that 22% reduction in the remaining lifespan. Now, the question is, who is surgical candidate? Surgical candidate BMI more than 35 with any comorbidity. This 35 has recently been reduced to 30 by American Bariatric Association. So, if it is 30 BMI and patient has any comorbidity, this is up to you. You can write that patient BMI 30 and patient is depressed, then also it is a comorbidity, or patient wife wants to divorce, then also it is a comorbidity, because it is a social comorbidity, psychological comorbidity. So, then you can do the surgery, but if BMI is less than 30, you are not allowed to do any invasive procedure. Just by the consent of the patient you cannot operate. The patient is 28, 29 BMI and comes to you and requests you because she is a model or she is a celebrities and she wants to look zero figure, and she will tell, I will give you money, this is my consent paper, do the bariatric surgery. If you will do for BMI 25, 28, then you will be penalized, because only the patient consent is not important. As a doctor, if the patient give you consent to remove my kidney, you will not remove it. If you remove it, you will be punishment. So, that is why it is not good. And if BMI is more than 40, then you do not need any comorbidity. You do not need any comorbidity. Directly the bariatric can be performed. Traditionally, age should be 18 to 60. Less than 18, bariatric surgery should be avoided, because less than 18, if you will do bariatric surgery, there will be chances of development problem, and more than 60 also it is. But there is one surgery like sleeve gastrectomy. Sleeve gastrectomy started becoming a popular in pediatric bariatric procedure. If you will search in the Google and if you will put the sleeve gastrectomy for 2-year-old child, then it is performed. In USA, it is a punishment. If your child is morbid obese, the parents has the punishment, because if child is morbid obese, that means you are not taking care of the child, and that means your child is getting overeating, because you are avoiding the child, you are not telling them to leave it properly, and it is on the maids only, and the maid is sleeping, and child is taking the from the fridge, and the child is taking, these are the for the 2-year-old child. Obese 2-year-old child has weight loss surgery done. CNN, CNN is one of the very important news channel from America, and this is Saudi boy who has a morbid obesity at the age of 2 years. Why? Because overeating, and that way if it happens in USA, then there is a penalty to the parents, and after 1 or 2 warning, if the parents will not stop eating their child, because 2-year child does not have money to buy from the market, that means you are feeding, and if it will be happen, then they will take the child from the parents and they will give to the other persons to take care. So, these type of bariatric problems are happening, which is completely revolutionized the way how it has been treated, but traditionally age should be 18 to 60. Pediatric bariatric surgery is not a very common procedure which you should do in every pediatric case. Non-endocrine related of the obesity is also sometime a cause, like type 2 diabetes. Sometime bariatric surgery is performed to treat the diabetes. Yes, and patients who should be dedicated for the permanent lifestyle changes, and patients should be compliant with the surgeon's advice, and there should be a team of a dietitian and the physician and the psychiatrist and the surgeon who will take care of. Who is not a surgical candidate? Active substance abusers, patient who is drug addicts, they are not a good candidate for surgery, because they did not take the advice of the dietitian. Suppose you have done the gastric banding or some other obstructive procedure, and they will take a big piece of bonus, they are taking a lot of alcohol, they will not take, suppose you did the bypass, they did not take the daily supplement of vitamin, they do not take the daily calcium, and they will die due to the complication of the surgery itself. So, that is why you should not do in active substance abusers, non-compliant patient, and patient who has severe psychiatric disorder like the schizophrenia, severe depression, and compulsive diseases or borderline personality disorder. These patients are not a good candidate for the surgery. We should avoid doing the surgery in those psychiatric patients. Psychiatric evaluation you have to send. If you have a doubt, send for psychiatrist evaluation, and if psychiatrist give you the letter that this patient can be performed the bariatric surgery, then you should do it. Now, surgical options, you have 3 options, either restrictive or maladjuvative or combination. Most common restrictive options are lap band, vertical banded gastroplasty and sleeve gastrectomy. These are the most common restrictive. Lap band is almost obsolete. It was old procedure. Nowadays, we are removing the band more than applying it. Sleeve vertical banded gastroplasty also does not work better, because vertical banded gastroplasty you will apply the band, but this band is not adjustable. So, in due course of the time upper stomach will dilate and this also become loose. A sleeve gastrectomy is good restrictive procedure which is still valid and people are doing it. Sleeve gastrectomy has an advantage, it is a simple procedure, it does not create any problem with the metabolism and it can be easily patient can tolerate it. Now, jejunal bypass is a maladaptive procedure, that also is not very practical of due to complication. Now, combination procedure is Roux-en-Y gastric bypass. Roux-en-Y gastric bypass is the most commonly performed bariatric surgery in the United States of America, because the people are very much educated and people have money to go to the doctors every time, because after gastric bypass patient has to take everyday vitamin B12, weekly vitamin B12 injection, daily 1000 milligram at least this calcium, and all these has to be taken, either otherwise patient will get hypomineral, hypovitaminosis and the problem. So, this has to be taken care of. Now, biliary pancreatic diversion or duodenal switch also has a mortality of duodenal switch is approximately 2%. If you see mortality during the surgery or perioperative, in the lap band it is 0.1%, in the sleeve gastrectomy it is 0.2%, in the gastric bypass it is 0.5 to 1%, and in the duodenal switch it is 1 to 2%. So, you can understand that doing the more aggressive surgery means more chances of death. 1 in 100 death in bypass happens. This is not a data of the beginners or who has started doing it, it is a average data all over world it is accepted. So, I will not discuss the vertical banded gastroplasty, in which what is done, you have to fire one stapler here and you apply one band over the stomach. We will not discuss the lap band also, if time permits later I will discuss the lap band. I am just discussing the sleeve gastrectomy which is the most commonly performed procedure in India. Do you know why? We do not do bypass more, people are trying to make the mini gastric bypass and then trying to convince the people, but in tropical country like India bypass does not have the much benefit. And moreover, even all over world if you will see that bypass is good only for the people who wants a quick resolution of the weight. Like suppose I will give you some idea, suppose the patient is already settled like a engineer, a doctor, a accountant who is already settled, they are not in hurry, then for sleeve gastrectomy has an advantage that it is a slow resolution. Do you know the maximum excess weight is lost in sleeve gastrectomy is only 40%, 40 to 60%, whereas in bypass 80% of the excess weight is lost at the end of 1 year. So, bypass is good for the people who are young like 18-year-old not getting married, because they are so obese and or their girlfriend does not like him and he wants to have the quick resolution of the all the comorbidity, joint pain and all, and very fast decrease in the weight, for them bypass is good. But there is a little risk of the life and lifelong supplement has to be taken, lifelong supplement has to be taken. That is why sleeve gastrectomy is more popular, because it does not create any problem with the meta. Sleeve gastrectomy is a accidentally invented surgery. Do you know some people who was very much obese, it was not possible to do the bypass in one go. So, what they were doing, first they were doing sleeve and after that in second stage was the bypass. But it was found that surprisingly just after sleeve also weight was dramatically reducing. Since that time it becomes popular as a separate surgery, separate identity, and you can perform this procedure. So, I will show you how to do. Just you have to put a varus needle same way supraumbilical or 18 to 20 centimeters of the umbilicus. After that put one mosquito and then you know the judge the depth of the fat. You use a 20 centimeter varus needle, and in obese patient you should go to the perpendicular to the abdominal wall, and after that you enter inside. Once you go inside, do the irrigation test, suction test and then plunger test. This is plunger test, because hanging drop test may not be so much effective. Plunger test, it is the plunger, this is the saline and it is sucking in. and this is the plunger test, and the fluid is going in, and after that you will attach the gas and you will start creating pneumoperitoneum. Once the pneumoperitoneum is created, then you will feel all around, you palpate it, and once you see everything, and then you put the trocar. You can use the disposable as well as reusable depending upon you, and once it is in, then you introduce the gas. Pressure should not exceed more than 15 millimeter of mercury. Do you know, in obese patients sometimes we think that more pressure will be helpful. More pressure is not helpful, because fat is so much in the abdomen that it will not lift the abdomen, it will press the vena cava, and the patient venous return decreases, and patient may have the problems. Now, one port right hypochondrium, one port left hypochondrium in the mid-clavicular line, and another is anterior axillary line. The anterior axillary line approximately 10 centimeter away from the first one. This one anterior axillary line is used for the purpose of the liver retractor, and other two is right and left hand. So, this is usual port position, because it is a simple surgery. So, you can put the liver retractor from the left side also. In fundoplication, you should not use liver retractor from the left side, otherwise there will be shorting, because you have to reach to the caudate lobe of the liver, pars flaccida, esophagus. But here you do not have to see that much. So, simple fan detector can lift the left lobe of the liver, and this is a fan detector which is lifting the left lobe of the liver. Just little retraction is required, and after that you will start doing the surgery. So, just after giving the retraction, you will hold it and then start firing it 6 centimeter. Pardon? 6 centimeter. 6 centimeter from the pylorus. Yes. No, no. What you are saying? For what? Port? Port you are saying. Do you know this also make like a baseball diamond concept. So, from the angle of his, it should be 22 centimeter away if you are using 45 centimeter instrument. Okay? And in bariatric generally 45 centimeter instrument is better to use. And then you will take a tape and you will measure from the stomach, pylorus, and then you will measure the 6 centimeter distance here. Some people they use 8, some people they use 4 also, and this is the distance which you have to measure from, and after that you will start cutting the short gastrics. Sometime you can use a tape also, like here you can see this is a companies, stapler companies are giving you the tape, and then you can measure. If you buy the staplers you get it, and here this is here 1, 2, 3, 4, 5 and 6, and you will give a small marking here by harmonic, just little bit, that is all. That means you remember this landmark from where you have to start. Sleeve gastrectomy is easier than a cholecystectomy. Do you know why? Nothing is required, only short gastric. There is no danger of CVD, there is no danger of Colors triangle, nothing. Just take a harmonic or ligashore and then keep on cooking. And here you will start from the middle and then go little towards the duodenum up to 6 centimeter and then go up. Do you know why? Because your instrument stomach is here, you cannot start from this side. So, start from middle, go little this and go little that, and nearer to 6 centimeter near the pylorus you do not have to remove even the short gastrics. And now you will start removing the short gastric till the end up to the fundus. In this situation you may touch the short stomach also. Even if you are touching, there is no harm, because the stomach is, it has to go out, and then you will be lifting the stomach like a bread. This is the way how you should lift the stomach, like a bread, how you are lifting, so that there will be no any chances of going your harmonic near the omental bursa or near the spleen. You have to be particularly very careful that you should not go near the spleen or near the pancreas. And now it is overdone. After that your work is only to do the short gastrics. After that all the work will be done by staplers. And staplers quality nowadays so good that they are completely risk free, but you can use sometime if you want, you can use the Gore-Tex tape over the stapler also. So, advantage of putting the Gore-Tex tape is that it will make it completely seal proof, or you can use the 5-in glue. Some people they do reinforcement suture, that after stapling it they take a continuous suture, so that reinforce the staple line. But generally nowadays we do not need it, because if you are doing sleeve gastrectomy you should believe on your stapler, you should have a belief, because and nowadays staplers are good. So, now you will hold it and you fire. Near the antrum you should use either the green cartridge green cartridge, or you can use the white. White is universal, white is basically used for vascular, but sometimes white can be fired at other places also, but the green cartridge is good, and for the body you will use a blue cartridge. So, you can hold it and then you fire, and during firing you have to be little careful that you have to put a orogastric tube, and orogastric tube has to be put in such a way that 36 French orogastric tube should be there, and it should be very nearer to the lesser curvature almost. So, I will just tell you that suppose this is the esophagus and here is the fundus, and then this is the lesser curvature. Now, there will be a orogastric tube. Some people, instead of the gastric calibration tube, they use the what they use? They use the endoscope, upper GI endoscope. You got my point? So that they can put the endoscope in the duodenum. They can put the endoscope in the duodenum, and this is the way how they put. And after that, this 6 centimeter you will leave and then start cutting. And from here you will cut like cut, and again when you go, you make a dog ear. This is important. This is a ear like a dog. I don't know, Indian dogs doesn't have this type of ear. Their ear is down, but Asian dog, their ear is like this. So, you will make a dog ear, and then you will cut in between here, and you will fire, and after that it can be removed out. So, do you know why the dog ear should be formed? In the old time, people have they noticed that this portion is removed, that much stomach is removed, and here this is like a ear of a dog. So, what is the advantage of a dog ear? That it will no leak. Sometime, yes, sometime if you will fire here at this time, then this area is weak, and here there will be leak at this point. So, to prevent the leak from the gastroesophageal junction in this area, the dog ear formation is good, but maximum effect of the sleeve gastrectomy is in the central part. So, you must take care that you should not try to go lateral. Like what I mean to say, that if you are doing it and you are leaving a lot of tissue there, just if you are leaving that much stomach or that much stomach, it is not going to give any benefit to you, because basically it is a restrictive procedure, because it is delaying the emptying of the food. It is delaying the emptying of the food. Normally when we eat, how much time it takes for the stomach to get empty? 2 hours. 2 hours, but after this it takes 6 hours, and then that is why we do not feel like eating, because if the food is there, ghrelin will not be secreted, and not only that, if food is there in the stomach, you will have the little feeling of heaviness and you cannot eat more. So, that is how it works. So, this area start from 6 centimeter, but here you should go as nearer as possible to the orogastric tube, and then you make a dog ear at this point. Here will be the dog ear. So, this is important, and that is why direction is going, this is lesser curvature. So, you will go as near as possible, and this is all the first gastric pedicle, second gastric pedicle, and then posteriorly also this is omental bursa, and posteriorly also you should try to touch almost your orogastric tube. So, that is just like a thumb, stomach should be left in the middle, just like a thumb, it should not be more than thumb, and it is very tight and it is done, and after that here also, and then fire, and this is it is cutting now. So, it is 3 row of a staple. Nowadays tri-staplers are there, which makes very nice, and if it is a bleeding, you can reinforce it by the clips. These are titanium clips which you can apply if it is bleeding, or it will press it and then bleeding can be minimized, and then again keep on firing and bringing as nearer as possible to the gastric calibration tube, and slowly this is blue cartridge now. And again it is, this is the main part which works. You can see so much less is there, that any food, you know, only one problem is there, that this surgery does not work for the carbohydrate eater. Yes, the people they take ice cream, the people they take soft drink, the people that it does not work, because that will not hold, it will come out. So, that is why patient evaluation is very important. For carbohydrate eater, gastric bypass should be performed better, and in those situations it does not work. So, here it is again applied, and then slowly again you keep on firing one over another. First firing will staple, subsequent firing is cutting 15, 30, 45 and 60. it will 4 times you have to fire 15, 30, 45 and 60 and then it returns back and then you can open it. Nowadays powered staplers are also there, which one time it cuts and it is battery operated, and these are nowadays auto staples are there, in which you do not have to worry about the color coding. It is just a gray color and you put it, or brown color, and then automatically according to the thickness it can adjust the size of the staple which comes. So, that technology is very advanced. In a stapler technology, Covidien is better than Ethicon. For laparoscopic instrument, for the trocars, cannula, Ethicon is okay, but for staplers Covidien has a better stapler in my opinion compared to Ethicon, and then you can keep on firing it. So, slowly here the lever retractor is lifting it up, and after that this is the third cartridge. Total approximately 6 to 7 cartridges is required to fire it. In the older time, sometime what people they do, that they try to corrugate the tissue to fire, so that with the less number of firing you can reach to the fundus, but that is risky, because if you want to corrugate the tissue there will be leak, because it should be nicely stretched, because if you are accumulating more stomach in one cartridge, that means you are making thick, and you are making a thick, a C will form, a B will not form. So, that is why a stapler firing should be good, and you should spread it as much as you can. So, that, and one stapler is costing you 11,000 rupees, cost of the gun is approximately 48,000 rupees, and one firing is costing you 11,000, and it is single use. After that you have to throw the stapler as well as gun. So, here it is fire and then it is reaching, and slowly with each firing you are going approximately 60 millimeter, and with each firing 60 millimeter it will cover, and now it is coming, and now you will reach up to the fundus. Once you reach up to the fundus, go towards the spleen, do not go towards the hiatus. Here this, can you see that this is the vessel, this is called as first gastric pedicle, that is, and then this is the gastroesophageal junction. So, you have to make a dog here and you need to go on the other side, so that you will not accidentally get your patient vulnerable to the leak. Nowadays Gore-Tex tape is applied over the stomach, so that it gives you the very good compression, just like the silk cloth you are putting a border and with the other cotton cloth and then stitching it like a fall, same way you will apply it here, and now it is done. So, surgery is over. After that you may have to look for bleeding. If you think anywhere there is a bleeding, you can reinforce with the titanium clip which you are using for cholecystectomy. Same titanium clip you can apply at 2-3 places and you can reinforce it with the titanium clip like that, and after that what you can do, if it is required you can put a fibrin glue, and you can make a fibrin glue which already you know how to do that, and you can spray, or you can directly with the applicator you can drop it by drop. You may not need CO2 cylinder to spray. CO2 cylinder which you have seen is used in hernia, but in cases of hair it is not necessary. So, just directly with the applicator you can apply fibrin glue like that, and that will take care, and if there is any chances of leak, it will keep it sealed there. It has a little bit hemostatic feature also.
Why did you use the last one was white?
You know, white is universal. Sometime if you have less cartridge, suppose you have many cartridges and you have less cartridge, like blue is only 4, now 5th is required, you do not have blue, then you cannot fire the green, you can fire the white. Do you know why? Why white is universal? This is interesting. And why green is not good where the blue is required? If you have a paper stapler for 50 papers and you will try to staple 2 papers, it will be loose, isn't it? But why white is not made? White design is different. Why? Vessels which look 8 millimeter, suppose you have to use a splenic artery, it looks 8 millimeter, but after compression it becomes 2 millimeter, isn't it? Yeah. Because once you compress it, blood is gone, and once the blood is gone, it is 2 millimeter. So, all the vascular staplers are self adjusting. In other staplers, I will show you the design of the stapler, how it makes, and other staplers, what happens, that suppose this is the stapler, then they bend it at this point. this is bend here. You got my point? There is a impression, there is a bend. What they do? They decide that where it should bend, and this portion they make it weak. So, when this tip will touch the face, it bend there. You got my point? And if it is a big stapler and thin, they bend it here, they bend it here, like that. But in vascular stapler, it bend at this point always. So, what happens? It goes like that and it bends this way. You got my point? So, that way it is self adjusting. So, that is why vascular stapler can be fired if you do not have the blue cartridge. But remember, blue should never be used for vessel, you will be in trouble, it will bleed. So, that is why vascular staplers are universally used in some time if you do not have sufficient number of cartridges. And on the top, especially near the gastroesophageal junction, white is better also compared to blue. Yes,
So where we can
because leak chances are there. Yes.
what's happened, doctor, with the stapler that is fallen in there?
Generally nothing happens because it is so small and the point is not pointed, it is bent, so nothing happen, it get fibrous somewhere. It is not like the titanium clip which is big and which can go there. It is very thin, very small, and so nothing happens. But if you are seeing in front, you may put a stone holding forceps and you can try to bring it out. But even if you not remove, nothing happens. So, this way you can put in biliary pancreatic diversion. What is done? That you will fire it and then you will divert the duodenum at the other place. So, this duodenal switch, how it is done? All the short gastric will be removed. After that, you will cut the duodenum from the first part, so that bile should not be affected, bile should come, pancreatic juice should come. Just juxtapyloric you will cut. After that, what you do? You remove the stomach also, get a curvature, and then you should take a loop of the ileum and you should do gastrojejunostomy or ileostomy, and then the remaining bowel will be anastomosed side to side. So, what happens now? This portion does not have any enzyme and this portion of the intestine does not have any food. So, only the portion that much is working, because duodenum is switched to the other place, and after that patient weight will be reduced. But these procedures also are not very common. Now, weight loss surgery is not a cure, but it has to be used as a tool. Lap band, there are many risks, infection is there, erosion of the stomach is there, band can slip to the esophagus, damage to the esophagus while placing the band can happen. Sleeve gastrectomy, it has leak, it has nausea. Nausea, why had happened? There are 2-3 concepts of the nausea. One concept is that once the patient eat, because he is feeling the obstruction here, that is why getting nausea. Other people they say that because the greater curvature is no more secreting the gastric juice more, so there is a hyper salivation in the mouth and saliva increases more, that is why patient is getting nausea. So, these are the concepts. Possible need of bypass in future, as we know that carbohydrate eater it does not work. So, you may have not the satisfaction with the sleeve gastrectomy, then patient comes for bypass again in the future. Gastric bypass is good, but it is full of complication. If you see, there is a very big list of short term complication: wound infection, hernia, pneumonia, heart attack, bleeding, blood clots, stricture, dumping syndrome, gallstone, hair loss, dilate interruption, peripheral neuropathy, fistula, leak and death. According to the one of the study, that 0.5% is the average, and it sometimes goes to the 1% also. Active after substance care should be important, long term follow up is important, daily vitamin supplement, vitamin B12 and calcium all is required. This is a data published in the Annals of Surgery in 1995 there is a 14-year follow up of a gastric bypass series randomized controlled trial. In this you can see percentage of patient, number of patients and surgical complication, and this is a bypass, gastric bypass, vitamin B12 39%, 40% of the patient has deficiency, readmit 38%, incisional hernia 23%, depression 23%, staple line failure 15%, gastritis 13%, cholecystitis 11.4%, anastomotic problem 9%, dehydration 5.8%, dilated pouch 3.2%. These are the most common complication which is, and not only that, these are the most common complications, but other complications also exist. So, patient choice is important. Patient lap band is good, patient technical risk is very less, 0.1% only, mortality rate is there 0.1 only, but only 40% of the excess weight is lost at the end of 1 year and 60% of excess weight is lost at the end of 5 years. Exercise is must, patient has to be positive reinforcement, and diet also restriction, carbohydrate diet patient cannot take, and intolerance also happen, but good advantage is that it is reversible. So, if patient does not like, it can be removed, and importance of realistic expectation, because lap band is not a realistic surgery. It does not give you the way how you are thinking about. Do not think that a patient who get lap band, that is 100% guaranteed that weight will reduce. Now, sleeve gastrectomy, it is good, lower risk than bypass, higher risk than band, and the complication rate is in between, and the reduction of the weight is more than lap band and less than bypass. So, approximately 60% of the excess weight is lost, and at the end of 1 year, and the gastric bypass, no dumping syndrome, no any supplement of vitamin or calcium, and no need of band refilling, no calibration is required. Gastric bypass, 80% of the excess weight is lost at the end of 1 year, faster resolution of comorbidity, but non-reversible, it cannot be taken back. So, that is one of the advantage of mini gastric bypass is that it is a reversible procedure, and it is short, effective and less expensive procedure. So, this is how about the gastric bypass. Surgical induced weight loss improves and resolves the comorbidity, decrease the early death, reduce the risk of developing obesity related illness, reduces health care cost, and improves overall quality of the life. So, that is why nowadays insurance company also started paying. In the old time, insurance was not paying for morbid obesity, but here if you are already having 4 or 5 year old insurance, then now they have to pay for morbid obesity, because generated letters has given the effect over the insurance company, and whenever you do any surgery, after response scheduled consultant is required, post operative dietitian should must consult, post operative physical therapy exercise also should be together, and optional behavior therapy also is required, and support group in which the surgeon, physician, dietitian and psychiatrist as a team, support group should follow up after every 2 weeks, then after 6 weeks, then after 6 months, and then yearly. Once a year, all the patient who has gone for the bariatric surgery should must be seen by the surgeon and the support team, so that they should not develop any complication, and this way you can control the obesity and you can beat the obesity. So, thank you very much.